Welcome to your second day of classroom training for the position of Emergency Department Medical Concierge. During yesterday's session, we briefly covered an introduction to the review of systems. Today, we'll continue to work on the review of systems and also begin covering the physical exam. First, let's quickly review yesterday's main points. So, Synergy's mission statement. Synergy Medical is dedicated to providing premium concierge services that support the delivery of high quality, efficient, compassionate care in a collaborative environment. In our company, we continuously emphasize the importance of a culture of positivity, support, and collegiality. In the emergency department, we have a really great workplace dynamic for all of the ED staff, including doctors, nursing, medical concierges, residents, and more, really work together to provide high quality care. The emergency provider has four main roles: stabilizing and resuscitating patients, diagnosing them, initializing treatment, and dispositioning the patients. The function of the medical concierge is to help the emergency provider. We provide documentation services so the provider can focus on treating the patient, but we also help them collect lab results and ancillary studies, manage phone calls, and communicate with patients with the same focus of helping them to provide high quality medical care. We also work to make sure the patient's emergency department is as comfortable and patient driven as possible. We'll also quickly review HIPAA. HIPAA is a set of regulations in place that require people who work in healthcare, including in Synergy, to protect patient privacy. This means that you should not be accessing any patient information unless you are involved in their care. You must also refrain from sharing patient information unless absolutely necessary. The medical chart has three main functions. It exists as a medical record. It is used for billing for reimbursements that fund the emergency department and its providers. It is a legal document to substantiate high quality care administered in our ED. For these reasons, it is extremely important to be comprehensive and careful in your documentation, as mistakes can have lasting repercussions. The four main sections we discuss in our training are the HPI, the ROS, the PE, and the MDM. The four main sections we discuss are the HPI, ROS, PE, and MDM. We do provide concierge services for the patient and family. You should be interacting with the patient and their family at least 3 times during their stay in the emergency department. During the initial interaction, you can introduce yourself and set an initial outline of the emergency department course. This includes their plan of care and NPO status, which is whether or not they can eat or drink. You should do this after the physician's initial interview and physical exam. You should also take this time to ask an initial support question. Is there anything else I can do to make you more comfortable? You should also have a follow-up interaction later during their department stay. How are you doing? Is there anything else I can do to make you more comfortable? And finally, you should have a disposition interaction. You can tell them, it was a pleasure taking care of you today, and we hope that you are completely satisfied with your care. At this time, you can also print the results you've been tracking during the patient's visit for them to take home to follow up with their doctors. We also provide concierge services for the emergency provider. You can assist your emergency provider with documentation support, which is the focus of our training right now. You'll document the HPI, ROS, and PE during and immediately after the patient interview and examination. You should also be tracking progress through the patient visit, which can be documented in the MDM. This includes radiology reports, phone call placement, occurrence of discussions with consultants, reassessments as requested by the physician, and critical care time, which we will discuss in a later session. There are also multiple non-documentation related tasks that are very important in supporting your emergency provider. Therefore, it is important that you are available and attentive, you're proactive and taking initiative, you are vigilant regarding ancillary studies like labs and reports, and you are available to place outgoing phone calls. Now we are once again going to review the 5-step method for crafting your HPI. Following this method will help you to organize patient information into a well thought out HPI that writes itself in structure and is highly effective in communicating patient information to the recipient. So step 1, you establish a chief complaint. This is usually the most pressing problem the patient has. If you're not sure what the chief complaint is, the doctor will often ask the most questions regarding the chief complaint to the patient. Step 2, you craft the first sentence. This should include age, gender, pertinent past medical history, chief complaint, and basic timing. It should follow the following sentence structure. The patient is a 42-year-old female with a significant past medical history of asthma and current cigarette smoking who presents with 2 days of cough and fever. In general, your sentences should follow the structure of the patient is a blank-year-old blank with significant past medical history of blank who presents to the ED complaining of blank for blank duration. Step 3. Describe the elements describing the chief complaint. In review, these elements include onset, presentation, quality, radiation, and severity of the patient's symptoms with any modifying factors, anything that makes it better or worse. Step 4. You include associated symptoms. Remember, it is important to include both related symptoms the patient is and is not experiencing. And finally, step 5. You include any significant pre-hospital events, outside doctor information, and any other pertinent information that might help communicate what's going on with the patient today. As you are writing your HPI, remember to keep the elements describing different complaints separate and in series. If your patient complains of both chest pain and shortness of breath, for example, you should not go back and forth between chest pain and shortness of breath, listing elements that describe their symptoms. Rather, elements of chest pain should be described together, then elements of shortness of breath should be described together. The order of your complaints should also be chronological if possible. If the shortness of breath preceded the chest pain, you should first describe the shortness of breath, then the chest pain. This is more logical and easier for the recipient to understand. Some further tips for crafting your HPI. Keep your HPI subjective. Do not use diagnostic or objective terms here. Use simple sentences rather than compound sentences. Again, this is easier for the reader. Your documentation must contain all of the pertinent details of the patient interview, and less is usually more. We are not writing literature or essays for an English class, so avoid unnecessary language and wording. Brevity and clarity are key in medical documentation. Here is another example of an HPI. Try to review all of the key points we discussed as you read along. The patient is a 68-year-old male with significant past medical history of hypertension, hyperlipidemia, type 2 diabetes, cigarette smoking, who presents to the emergency department with 1 week of intermittent chest pain. He describes the chest pain as occurring only with exertion, particularly when he is walking up the 2 flights of stairs to his apartment. He describes it as dull ache, 4 out of 10 in severity, localized to the substernal area, with radiation to the left shoulder. It resolves after approximately 5 minutes once he rests at the top of the stairs. It is usually accompanied by nausea, sweating, generalized weakness. He came to the emergency department today when he experienced the same symptoms at rest. They lasted 15 minutes and then slowly resolved. This time the pain was severe, 10 out of 10 in severity. He called EMS and was transported to the emergency department. He denies dyspnea, dyspnea on exertion, orthopnea, lower extremity edema. He denies cough, fever, chills, or sweats, and he denies rash. EMS administered 324 milligrams of aspirin. His primary care physician is Dr. Smith, and his cardiologist is Dr. Jones. You can see this HPI followed the 5-step method we went over before. They identified the chief complaint. They constructed the first sentence, listed the elements of the chief complaint, listed the pertinent positives and negatives, and included the pre-hospital events and other pertinent information for the patient's visit. Now we're going to return to discussing the Review of Systems, or ROS. The Review of Systems is designed to identify symptoms a patient may be experiencing of illness in various organ systems. It is done by a succession of questions asked by the provider during the patient interview, and the Review of Systems is often documented by templates. Templates must be meticulously edited for each patient. You have to eliminate what was not asked and highlight what is pertinent. It's important you cross-check for symmetry with the HPI, as the 2 sections are not entirely exclusive. There are various templates for the ROS that are subdivided by age and complexity. You may see an adult comprehensive, or an adult basic, or pediatric basic. These are just a few examples of the templates you may see. When you document the review systems, you have your own ROS section in Meditech in which you'll document. Here's an example of one of the templates that you might use. This is the Adult Comprehensive Review of Systems. The review systems is organized by organ system, so you have constitutional, which is like general, HEENT, which stands for head, ears, eye, nose, throat, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, skin, hematologic, immunologic, endocrine, neurologic, and psychiatric. Take a moment to read through some of these systems. Again, you should notice that these are all subjective findings. These are all things that the patient may or may not be experiencing, again, subjectively. Here's an adult basic review of systems. As you can see, it's less comprehensive and it addresses less complaints. This is usually for patients with lower acuity complaints. Here's a pediatric review of systems. Again, these are very important to edit meticulously as different cases require different pertinent positives and negatives and will address different systems and different complaints and findings. Here are some definitions for the terms that you may see in the review of systems. Make sure that you are entirely familiar with these definitions, not just these, but all definitions that you've seen in the previous templates because you will be tested on them when you return to the classroom for the classroom portion of your training. So in general, you may see malaise. This is a generalized feeling of discomfort or illness. When you're feeling sick with the flu and you feel like you've been quote-unquote hit by a truck, that's malaise. Diaphoresis is another word for sweating. In HENT, again, which stands for head, ears, eyes, nose, throat, rhinorrhea means a mucousy discharge from the nose. When your nose is running, you're experiencing rhinorrhea. In the neck, you may experience lymphadenopathy. These are enlarged lymph nodes. In cardiovascular, you may experience palpitations, which is when your heart is beating fast or a sensation of an abnormal heartbeat. Syncope, which is a loss of consciousness, which is due to hypoperfusion of blood to the brain. Basically, loss of consciousness, briefly, or when you faint. Peripheral edema is swelling in the periphery, meaning swelling in the arms or legs. Dyspnea is shortness of breath, and dyspnea with exertion is shortness of breath with exertion. So shortness of breath when you're walking or exercising. Orthopnea is shortness of breath when supine or lying flat. In gastrointestinal, you might experience abdominal distension. This is when your abdomen is swollen and protrudes from your body. There's melena, which is dark, colored, sticky feces, and hematochezia, which is red or maroon colored, bright red, bloody feces. In genitourinary, there's dysuria, which is a burning sensation when you urinate. Urinary frequency, which is frequent urination. Urinary urgency, or the sudden urge to urinate. Urinary hesitancy, or the hesitancy of the urinary stream. It's not coming out as forcefully as it normally would. And hematuria, bloody urine. In musculoskeletal, there's myalgia, or muscle ache, and arthralgia, joint ache. And in skin, there's pallor, or pale-colored skin, and erythema, which means. Now we will start to cover the basics of the physical exam, or PE. While the HPI and ROS are subjective accounts from patients, the physical examination is the objective findings of the patient-physician encounter. The PE is sometimes performed in parallel with the HPI rather than in series, meaning the provider will often examine the patient while asking them questions, so it is important to observe the interaction in great detail. Findings will often be called out to the medical concierge in real time or after the patient encounter. However, some findings may be visually apparent to the medical concierge, so again, it is important to be very observant during the entirety of the patient interaction. Things you may observe include level of arousal, appearance and level of distress, body habitus, so whether they're very thin or maybe obese, cough, vomiting, active bleeding, diarrhea, sweating, and then finally pallor or the way the skin looks are some things you may observe visually during the physical exam. That being said, all charting must be directed by the provider. You should not document anything in the physical exam without being directly told to do so. The physical exam will be documented in the PE tab within Meditech. Like the review of systems, the physical exam also utilizes templates for increased efficiency, consistency, and attention to detail. Again, templates must be used responsibly and edited appropriately. You have to go through them meticulously to make sure that all pertinent positives and negatives are included, and anything that was not addressed is omitted from the template. Here are more examples of templates you will use. This time they are for the physical exam. As noted for review of systems, there are different templates based on varying degrees of complexity. Again, you must be entirely familiar with the terminology in the included templates prior to coming in for your classroom training, as you will be tested at the beginning of your training session. Here are some definitions that you should know, but again, like I said before, you must be entirely familiar with all of the terms, so please use all resources that you have to make sure that you have mastered the terminology. In HEENT, you may see normal cephalic, that means there's normal shape of the head. Atraumatic means no evidence of trauma. PERRLA means pupils are equal, round, and reactive to light with accommodation intact. EOMI means extraocular movements are intact. Conjunctiva pallor means conjunctiva of your eyes are pale. And sclera are non-icteric means that the whites of the eyes are not yellow. Neck, you may see supple, which means that the neck is flexible and not stiff. There's full ROM, or range of motion. JVD is jugular vein distension. Bruits are turbulent whooshing sounds heard over a blood vessel. Thyromegaly is an enlarged thyroid. And again, lymphadenopathy is enlarged lymph nodes. In the heart, murmurs are sounds created by turbulence as blood passes over a heart valve. Pericardial friction rubs are sounds created by friction as pericardium rubs against endocardium. And gallops are abnormal extra heart sounds other than S1 and S2. In lungs, rales or ralls are crackling lung sounds. And rhonchi are low-pitched rattling lung sounds. In the abdomen, if it's non-distended, it's not swollen. The opposite of that would be a distended abdomen, which is swollen and protrudes. This is different from a fat abdomen. Rebound is pain upon removal of pressure to the abdomen. Guarding is voluntary or involuntary tensing of abdominal muscles to prevent deep palpation. Organomegaly is enlargement of organs. And normal active bowel sounds is normally active bowel sounds. That means they're not moving too fast or too slow. CVA tenderness is tenderness to palpation at the costovertebral angle. This is along the sides of your mid-back. And your bonus term is auscultation, which means listening to organ sounds, usually with a stethoscope. So you can auscultate the heart, lungs, and abdomen. For skin, some terms to know are cyanosis, which is a bluish discoloration. Clubbing, which is loss of depression at junction of nail bed and finger with a domed junction. And edema, which is swelling. And jaundice, which is yellow discoloration. And neurological, you should know ataxic gait or unsteady gait caused by loss of motor coordination. Again, make sure you know all of these terms. Feel free to use Google to identify what they look like and what parts of the body that they are referring to if you're not entirely certain.